Hi, I'm Jim White, an associate professor at the University of Rochester in Rochester, New York. In previous programs, we've discussed the strategy for selecting combination therapy and the ways that we might reevaluate patients who present on monotherapy and need treatment escalation. In this program, we're going to discuss the adverse events associated with combination therapy and pay particular attention to whether any of these adverse events with the individual therapies are more likely when we use the therapies in combination. Happily, the answer seems to be that problematic side effects are not more common with the combinations of therapy as compared to when we use the therapies individually. As all of you know, the endothelin receptor antagonist bosentan presented significant safety problems at the time of its launch. Although this drug was incredibly successful in the care of our patients with pulmonary hypertension as the first orally available therapy, although this therapy was highly successful in the care of our patients as the first oral therapy for pulmonary hypertension, the problem of monthly lab work became an increasing burden to our patients as alternative therapies became available. The introduction of ambrisentan reduced the apparent risk for transaminitis, and ultimately ambrisentan was shown to be completely free of liver-related adverse effects. The current FDA label has no reading for hepatotoxicity and no recommendation for routine monitoring of transaminases. The introduction of macitentan was certainly an improvement over its cousin bosentan, especially at the 10 milligram dose approved. The incidence of clinically significant transaminase elevation is much less than with bosentan. However, the FDA label does warn of a dose-related approximately 2% risk of clinically significant transaminases. Transaminase monitoring is not mandated at any regular interval, but many clinicians do check transaminases periodically because of the modest but not zero risk of transaminase elevation. Happily, there did not appear to be any increased risk of transaminase elevation when macitentan was combined with sildenafil in the Seraphim trial. This is in sharp contrast to the combination of bosentan and sildenafil. In the COMPASS trial, the combination of bosentan and sildenafil markedly increased the overall risk of transaminase elevation to greater than 20% and at least 16% above placebo. There's no apparent increased risk for macitentan and sildenafil, as I said, and no risk for transaminase at all with ambrisentan. In terms of the combination of an endothelin receptor antagonist like macitentan and a phosphodiesterase 5 inhibitor like sildenafil produces nuisance-level nasal congestion. The combination of ambrisentan and tadalafil may have the worst nasal congestion, at least in my clinical experience, and I think ambrisentan has more nasal congestion than macitentan or bosentan. Other colleagues that I've talked to share that opinion. Of course, the combination of ambrisentan and tadalafil was highly successful for patients enrolled in the recently published AMBITION data, and headache and fluid retention were both more common in patients treated with the combination. However, and this is important, drug discontinuation because of adverse events was not more common in the group treated with initial combination therapy. Therefore, although it's probably fair to say that side effects are more likely with a combination of an endothelin receptor antagonist and a phosphodiesterase inhibitor, those side effects are usually not problematic enough that patients need to stop drug. With regard to riociguat, the soluble guanylate cyclase stimulator, there are a few special side effects that we should attend to. The first is the rare but not zero side effect of hemoptysis. If this is observed in a patient being treated with riociguat, care should be taken, and one might consider interrupting the drug to see if that problem resolves. Although unusual, riociguat was associated with hemoptysis different than placebo and apparently different than our other drugs used in the treatment of pulmonary hypertension. Happily, this does not seem to have increased in occurrence during commercial use of the drug over the past 3 years. But in talking to my colleagues, they still have occasionally seen hemoptysis. Hypotension is certainly more common with riociguat than with the other drugs that we commonly use in this disease. However, symptomatic orthostasis and actual syncope remain rare. So, although measurable hypotension is observed, the problem is not usually associated with symptoms the patient detects or a need to discontinue the drug. Importantly, in the patent study when riociguat was combined with bosentan, neither hemoptysis nor symptomatic hypotension or syncope were more likely. Thus, although these unusual side effects of special concern with riociguat do occur, they don't appear to occur more frequently in combination. This has certainly been true in my commercial experience using the drugs. Of course, we discussed the fact that high-risk patients should be considered for parenteral prostacyclin therapy, and that lower intermediate risk patients not meeting treatment goals might benefit from parenteral, oral, or inhaled prostacyclins. These drugs are by far our most problematic drugs in pulmonary hypertension, especially with regard to the complexity of the delivery system and treatment-related side effects. Of course, experienced clinicians are able to manage these side effects and make the drugs usable for patients. Nonetheless, headache, nausea, flushing, diarrhea, and leg and back pain are commonly observed with the parenteral and oral forms of these drugs especially. Cough is more common to the inhaled form, and some patients also have headache with the inhaled form, probably due to the modest amount of systemic drug delivery. In my own experience and in the experience of some of our research studies that are placebo-controlled, patients who take prostacyclins in combination with other drugs do have more intense problems with headache, nausea, flushing, and diarrhea. However, this doesn't usually limit the utility of the drug, but rather just limits the speed at which dose increases are made. Of course, the delivery system itself is associated with sepsis, endocarditis, and thrombosis when one considers the IV forms of epoprostenol or treprostinil. The sub-Q form of treprostinil is definitely associated with infusion site pain, and although this can be controlled, it is essentially universal. And as I said before, the inhaled form is most tightly associated with cough, unique to the delivery system. Thanks very much for joining me for this Minute CME program. I'm Jim White from the University of Rochester, wishing you the best.